Hello again, I'm Dr. Jonathan Jones. I'm a rheumatologist at Samaritan Rheumatology in Corvallis, Oregon. And thank you for watching these videos. Today I'm going to talk with you about the evaluation of someone complaining of joint pain and what labs we might order and what the labs mean. Now, many of these labs are not clearly understood, and I hope to make those more clear to you today so that as you order them and get the results, you have an easier time interpreting those labs. We're going to focus on the following labs: an erythrocyte sedimentation rate, or ESR, a C-reactive protein, or CRP, rheumatoid factor, CCP antibody, and the ANA. So let's start with the SED rate. The erythrocyte sedimentation rate, or commonly known as ESR, is reported in millimeters per hour. It's important to understand what this test actually is. You know it to be a marker of inflammation, but this slide illustrates how the test is actually done. Historically, blood from the patient would be put into a column and the column would be placed next to millimeter markings. Nowadays, the ESR is automated and can be run in a shorter time than an hour, but it's still reported in millimeters per hour. As you get the blood into the column, you then start the timer, and in 1 hour you see how far the red blood cells have sedimented or dropped, leaving plasma above the red blood cells. This then allows you to determine what the ESR is. Let's focus on the last 4 tubes in this slide. Here is the final result after 1 hour. If you look at patient 5, you would record this ESR as 71 or 72. If you look at patient 6, you would record the ESR as 80. Patient 7 has an ESR of 0, while patient 8 has an ESR of 105. The important thing to know is that there are several things that influence how quickly the erythrocytes will sediment. The reason this works as a marker of inflammation is that all the excessive inflammatory chemicals, including antibodies, will change the charge of the red blood cells so that they can more easily form rouleau and therefore cluster together and sediment more quickly. But it's not just inflammation that will cause the ESR to rise. This could include other things, including other proteins, and especially other antibodies. A common reason for an elevated ESR but normal CRP is someone who has a paraproteinemia, such as multiple myeloma, not because of an increase of inflammation, but because of the excessive antibodies. So if you have someone who has a discrepancy in the ESR, where that's high but the CRP is normal, it's worth doing a quick look at a table of other items besides inflammation that will cause the ESR to be elevated to make sure that you're not missing some other explanation. The C-reactive protein, or CRP as it's often referred to, is another marker of inflammation. This is a protein as evidenced by the name, and so when this is measured, it's usually done by an ELISA. This protein is actually used by the body as an opsonin. An opsonin, you may recall, is a protein that sticks to bacteria, making it easier for phagocytes to engulf the bacteria. So the CRP will actually stick to bacteria, and therefore not only is it a good marker, but it has a good functional purpose, especially in the setting of infection. What I mostly want to point out to you is the difference between a standard CRP and a high sensitivity CRP. Many of you will recognize that both of these are options. You can order either of them, but it often gets confusing about what the difference is. I have some providers who think, well, a high sensitivity CRP must be better at picking up on inflammation, so if I'm concerned someone has an inflammatory disease, I better choose that one. But that's actually not the case. The difference between the CRP and the high sensitivity CRP is a matter of concentration. Specifically, the CRP is milligrams per deciliter, and the high sensitivity CRP is milligrams per liter. The reason this came about is because of cardiologists in Boston who recognized that patients with increased inflammation had a higher risk of heart disease. And so they were looking for another way to stratify cardiac risk in people for primary prevention. If someone didn't have the common risk factors like diabetes or strong family history or smoking, but still had there was still a concern for an increased risk, they hypothesized that measuring the serum CRP could further differentiate those who have a higher risk. The challenge is that those who have an autoimmune or systemic inflammatory condition already have a higher cardiac risk, so that wasn't helpful. So what the cardiologist wanted to do was see if there's a difference in those with a normal CRP but who have a high normal CRP versus a low normal CRP. The challenge in that is that every lab has room for error. And so distinguishing between 0.8 or 0.5 might be very difficult when we're thinking about just the CRP. So these cardiologists said, what if we increase the dilution and therefore we have much higher sensitivity as we measure the CRP? So now instead of a normal CRP being measured at 0.4, now a high sensitivity CRP will be measured at 4.0. And this way, because of lab error, it becomes much easier to distinguish between 4.0 and 6.0, whereas if you use the standard CRP, 0.4 and 0.6 really are not that different when you take into account lab error. So this is why high sensitivity CRP came about. It really was developed looking at the low positive CRP levels to see, or sorry, looking at patients with a low CRP, but then trying to stratify if within the normal CRP there's a difference in cardiac risk. Now, some labs will still use the high sensitivity CRP exclusively. Most labs you can choose between the CRP or the high sensitivity CRP. This is really important when you're looking at the CRP result. For instance, if someone has a CRP and it's listed as 15, if it's a normal CRP, that's really high. That's a very high marker of inflammation. However, if it's a high sensitivity CRP, that's actually that's very close to equivalent of 1.5 on a normal CRP, which is still elevated, but not nearly as high as if it were 15. And I have seen some clinicians fooled by not recognizing they were reading a high sensitivity CRP and thinking that that level was very, very high. So I would encourage you to always look at the units, always look at the normal range when you're looking at CRP, and when you're recording the CRP, please make the effort to put the units in there so that people know if you're talking about the regular CRP or the high sensitivity CRP. Okay, we're now going to talk about rheumatoid factor and CCP antibodies. Now, the first thing to ask yourself when we think about rheumatoid factor is, what are we actually measuring? Is this a protein? Is this a dynamic test? Well, rheumatoid factor is an antibody. And when we're thinking about antibodies, it's important to ask, what is the antibody targeting? We know that antibodies are really good at sticking to one target. So what is the target for rheumatoid factor? Rheumatoid factor is unique because it's an antibody that targets other antibodies. Now, if you remember the form of an antibody, we typically break it down into the upper part, which is the FAB portion, and the lower part, which is the FC region. The FAB is the part that's specific for that antibody. It's how we know where it's going to stick to. The FC portion relates to the tail, which help us determine if this is an IgG, an IgA, an IgM, etc. This is where many things will attach, such as complement or FC receptors. Rheumatoid factor specifically binds to the FC portion of human IgG. That's what makes it unique. Most of the time, rheumatoid factor is an IgM pentameric antibody. And we think that the most likely reason that we have rheumatoid factor is that those 5 arms sticking to other antibodies are really convenient for making immune complexes. In fact, we all have rheumatoid factor. Most of us just have it at such a low level that we can't measure it. But if you were to get a bad viral infection, your body might increase the production of rheumatoid factor to help clear immune complexes. So you might transiently get an elevation in your rheumatoid factor. That's important because recognizing that rheumatoid factor is not just a marker of rheumatoid arthritis. We definitely see it in rheumatoid arthritis, but you can see it in many other diseases. In fact, if you are measuring both rheumatoid factor and CCP antibody, and you find that the rheumatoid factor is positive, but the CCP is negative, that could still be rheumatoid arthritis. But that's a good time to pause and look up in whatever reference material you have to identify other diseases that will cause an elevated rheumatoid factor to make sure you're not missing something else, like Sjogren's syndrome or sarcoidosis or something like that. Now, the other antibody I want to talk about right now is the CCP antibody. What is CCP? This stands for cyclical citrullinated peptide. What we are measuring here is also an antibody. Now, what is the cyclical part about this? This sounds kind of funny. Well, really what this is describing is simply what the test looks like. So if I slide over, this is a diagram of an ELISA well. And in the well, you put the antigen of interest at the bottom of the well so that when you then add serum, if there are antibodies to that antigen, they'll stick. The problem is that oftentimes when you put the antigen at the bottom, the target might be stuck down or focused down, so it's harder for antibodies to stick to. So what they figured out is if they can make a protein chain that is cyclical and have the citrulline, which is the antigen of interest, pointing upwards, then it's easier for the antibodies to stick. That's all the cyclical part is. So in reality, what these antibodies are targeting citrulline, which is an amino acid that comes about as a post-translational modification. We all have citrulline in our body, but very few of us have antibodies to citrulline. We call it the anti-CCP antibody because of how the test is done. Some literature will refer to them instead as anti-citrulinated proteins because the target actually is citrulline and not just the cyclical part of it. But that's the anti-CCP antibody. Now, these are both antibodies found commonly in rheumatoid arthritis and are very helpful when we're trying to determine what form of inflammatory arthritis a patient might have. The next test that we want to talk about is the ANA. And you'll know that this is a commonly used screening test for those who have joint pain or if you're considering a person who has autoimmune disease. I want to make sure that you know what an ANA is. So you'll recall that an ANA stands for anti-nuclear antibody, meaning that the antibody is sticking to something within the nucleus of the cell. This test is an immunofluorescence test. There are some ANA ELISAs, but for most institutions, it's the immunofluorescence that is reported. What this means is that the test is done using a microscope and a slide, the slide containing human cells. Usually, the ANA is reported as a titer, 1 to 80, 1 to 160. What that means is that it's the indication of how dilute the serum can be before the test is negative. A 1 to 40 dilution means that there's 1 part serum and 39 parts saline. So that mixture will be added to the slide, and any antibodies that are going to stick are allowed to stick, and the rest of the serum is washed off of the plate. Then a second antibody, which will target human IgG, but are also tagged with a fluorescent label, will then be added. And that way, the fluorescent label will stick to any of the patient's antibodies that are present. Then when you look at it under a microscope, you will see the green fluorescence where those autoantibodies are. And you can see that the titer is usually reported as a particular pattern. There are 4 patterns that you see on the slide now: homogeneous, speckled, nucleolar, and centromere. What those indicate is a rough idea about where the antibodies are sticking. Most of these are nonspecific. For instance, a homogeneous pattern could mean that the antibodies are sticking to any of numerous antigens. However, something like a centromere antibody pattern does indicate with high probability that there's an anti-centromere antibody. So sometimes those patterns are helpful, but if it's homogeneous or speckled, it's less beneficial for you. So if the test is positive at 1 to 40, now the technologist will get a new slide, will dilute that sample in half. So now it's a 1 to 80 dilution, and repeat the process. If it lights up green again, if it's still positive, then they do another dilution. Now it's a 1 to 160 dilution, and they continue to dilute the sample until it's no longer positive. So that would be a 1 to 160, 1 to 320, 1 to 640, 1 to 1280, 1 to 2560. So the higher the dilution, the implication is that there's a higher percentage or number of those autoantibodies that are still present in order to show up positive on the immunofluorescence. An important point about this test is that it is very technician dependent. First of all, there are several steps, and so there are opportunities for error because of the multiple steps. But secondly, the immunofluorescence that is seen might vary from one sample to another. Further, the amount of greenness that is present to consider it positive versus negative might vary from one technician to another. It doesn't just go from this bright green that you see in the homogeneous pattern to nothing. It goes from bright green to a lighter green, and where you cut off the positive versus negative can be a little bit tricky, and it's going to vary from technician to technician. At a previous institution where I was at, the technicians came and spoke to us and said that for every ANA that's performed, 3 technicians will look at the slide and they'll take the best for 2 out of 3 to determine if it's positive or negative. Why is that important? Well, I've had some people ask that this particular patient previously had an ANA that was positive at 1 to 80, and now it's positive at 1 to 160. So doesn't that mean that there's worsening disease, and doesn't that mean that we need to be more concerned about autoimmune disease? And in that situation, my answer is no. It's probably just a different technician or a different day, or there was a slight variation in how bright the light of the microscope was, or something like that. So this is definitely prone to some technical error. However, the ANA is a very good screening test for certain diseases, and so it's often used. The importance is recognizing that this is a screening test. It just means that there's an antibody sticking to something in the nucleus, but we still don't know what it's sticking to in the nucleus. Okay, now that we have a positive ANA, the next question is, what antigen are these antibodies targeting? We know that antibodies are sticking to something in the nucleus, but the more we can get a specific target, the better we will be able to identify if there's a specific autoimmune disease present. It's important to note that if you have a positive ANA but are not able to identify a specific antigen, that's less helpful. There are many healthy people who walk around with positive ANAs and do not have autoimmune disease. If, however, you have a specific antigen that we can measure, that increases the likelihood of having a specific autoimmune disease. It doesn't define it, but it increases the likelihood. This is why it's important when you order the ANA to request an ANA so that the lab will default to doing the specific antigen testing if the ANA is positive. In my institution, that test is an ANA with reflex to cascade. It might be different for different institutions. If I order an ANA with reflex to cascade and the ANA does come up positive, then I'm going to get testing for specific antigens. One of the ways that we will define this group of antigens is an ENA panel. That stands for extractable nuclear antigens. In other words, these are antigens found in the nucleus that we can isolate and see if you have antibodies to that particular antigen. Again, the reason these are helpful is that these often associate with a specific disease. So you will see that if someone has a double-stranded DNA antibody, or if they have an anti-SM or Smith antibody, then there's a much stronger association with systemic lupus. Similarly, if someone has an anti-Rho antibody, also known as SSA, or an anti-LAW antibody, also known as SSB, they have a much higher association with Sjogren's syndrome. Now, those patients might still have systemic lupus, but more often than not, Sjogren's is going to be the correct diagnosis. If someone has an anti-SCL70 antibody, that has a strong association with scleroderma. If someone has an anti-RNP antibody, that has a strong association with mixed connective tissue disease. And if someone has an anti-Jo1 antibody, that has a strong association with myositis. Now, importantly, these antibodies are not definitive, but they are helpful as you're trying to decide what particular autoimmune disease someone might have. This is important, again, as we're trying to define if someone has an inflammatory arthritis or an autoimmune condition. Having these specific antibodies help you more likely decide which specific autoimmune disease is present. Now, one of the patterns I want to point out to you is that I have shown you five of the most common ANA-associated diseases. There are others, but these are the ones that I typically think of first. Anytime you're about to order an ANA, it's worth asking yourself, is it likely that one of these 5 diseases are present? And if so, then definitely order the ANA. If it's unlikely, then it's questionable whether or not you should order the ANA. But I also want you to use this pattern to help you remember these 5 ANA-associated diseases. You will see that there are 3 S's and 2 M's. Systemic lupus, Sjogren's, and scleroderma are the 3 S's. Mixed connective tissue disease and myositis are the 2 M's. This is an easy way to help you remember the 5 most common ANA-associated diseases. Thank you for watching this video about lab testing in patients who have joint pain. I hope you've enjoyed it.